करून तर त्यात तुम्ही माईक आपली म्हणून चालू करू. हो जाए करप्ट થઈ ગઈ. Yeah. So good afternoon, everyone. So after the excellent session on communication, my hope in the next 20 minutes would be to discuss on a new molecule. So now, as such, it is not a new molecule in the Western nations. It has been available for a long time, and the injectable formulation has been available recently. So there are some technical issues. So till then, let us discuss. So diabetes is a very common issue. Almost 11% of the Indian population is suffering from diabetes. So of our Indian population, 110 million are facing diabetes. Now what we want is a single molecule. A single molecule which is able to control our blood glucose. At the same time, as we all know, diabetes is associated with a lot of complications. So we divide the complications into two parts. One are the microvascular complications. So that would be the involvement of the retina, the involvement of the nervous system, and the involvement of the kidney. And at the same time, there are macrovascular complications. So involvement at the level of the brain, involvement at the level of the heart. So we wanted a molecule which is able to control your blood glucose. At the same time, it is able to reduce the risk of complications. Now, as all practicing clinicians would know, rather than a patient to control your blood glucose, what is important for a clinician, what is even more important is to prevent hypoglycemia. So we wanted that all of this reduction in complications, the improvement in blood glucose should be happening with a very low risk of hypoglycemia. And then now it is very well known that obesity is almost a pandemic, and all the World Health Organization as well as all the national bodies have taken up the treatment of obesity as a priority. So and obesity is associated with more than 100 complications, and the most important complication of obesity is actually diabetes. So we want that a drug should at the same time also cause reduction in your body weight. So a single molecule which is able to control your blood glucose at a low risk of hypoglycemia with improvement in complications and at the same time causing loss of body weight. So this is where for a long period of time the problem was happening, and which has changed with the introduction of the newer molecule, that is GLP-1 analogs. So now how do these GLP-1 analogs work? At the level of your brain, there is the hunger center. So they are able to act directly at the level of your brain, and they can cause reduction in your hunger. Along with that, they can cause reduction in cravings as well. At the same time, at the level of your stomach, at the end of your stomach, there is a valve. So they increase the tone of the valve. So they are able to reduce the output from the stomach, and they are able to reduce your capacity of your stomach. At the same time, there is something called as the incretin axis. So what is your incretin axis? So anytime you are seeing the food, there is increase in insulin release from the pancreas. So this is happening through the cephalic phase, and this is happening because there is some molecules which are happening before there is the rise in blood glucose, and this molecule is actually the incretins. So they are able to activate your incretin axis 1,000 times more than what is there in your normal body, and this is what is able to cause insulin release and cause improvement in blood glucose. Now this is associated with a reduction in body weight, and this reduction in body weight will cause improvement in insulin resistance. So as you lose weight, your muscles are able to attract more blood glucose at the level of your liver. There is reduction in glucose generation from your liver. So this is called as the ominous octet. So the pathways of the ominous octet are that you are having more hunger, you are having reduction in insulin release from the beta cells of the pancreas, there is increase in glucagon release from the alpha cell of the pancreas. At the same time, there is increase in glucose output from the liver, there is reduction in glucose output into the muscles, and then there is activity at the level of the brain as well. So out of the ominous octet, 7 pathways are, sure. Done. So at the level from the ominous octet, that is the pathophysiology of diabetes, 7 mechanisms are combined and they are tackled by a single molecule, and that single molecule is semaglutide. So if we look at the data which is available with semaglutide, now it is used in more than 100 million population around the globe. Even in Indian population, more than 20,000 individuals have undergone randomized control trials for use of semaglutide. So as such, it is not a new molecule. It is commercially available in the injectable form for a very short period of time. And in that short period of time, it has caused a significant revolution in the management of diabetes, because this is a single once weekly injection which is able to control your blood glucose. At the same time, it is able to cause improvement in your insulin resistance. It is able to cause loss of body weight as well. So there are various trials. There is Surmount 1 to Surmount 5 trials which are available with this injectable molecules, and across all molecules what has been shown with semaglutide is that it is the most potent molecule to cause reduction in HbA1c. So up to the tune of 2% HbA1c reduction is possible with the single molecule, and there is only one drug which is more superior to semaglutide in terms of HbA1c reduction, and that is insulin, because insulin has infinite potential to reduce HbA1c. Rest, as compared to all other molecules, may it be DPP4 inhibitors, may it be SGLT2 inhibitors, sulfonylureas, pioglitazone, as compared to each and every other molecule, there is significant more reduction in HbA1c with semaglutide as compared to any other molecule. Now with insulin, the problem is that for type 1 diabetes, it is the main treatment available. So for type 1 diabetes, it is the only treatment option which is available. But for type 2 diabetes, when we use insulin in patients who have type 2 diabetes, while it is able to control your blood glucose, in some period of time, it leads to some increase in body weight. And what this increase in body weight does is that it causes increase in insulin resistance. So while you are giving insulin, it is able to control your blood glucose, but in some period of time, your weight will become more, and then your blood glucose, because of insulin resistance, will keep on increasing, and you will have to keep on slowly increasing the dose of insulin, and it will make your glycemic control more and more difficult. So this is where semaglutide comes into the picture, is that it is able to cause reduction in blood glucose, it is able to cause reduction in HbA1c with reduction in your body weight. Now it is, of course, it is associated with some side effects, and the side effects are mainly gastrointestinal in nature. So anytime we start a patient on GLP-1 analogs, we always explain to all our patients is that nausea, vomiting, diarrhea and constipation are very, very common. But what is very important is that these side effects happen in the initial few weeks only. They happen in the first 2 to 6 weeks, and with time, with the continued use of the drug, there is reduction in side effects, and we can use all the molecules to manage that nausea, that vomiting which happens with semaglutide. So we can use antiemetics, because the action of semaglutide is at the level of the pancreas and it is at the level of the brain. So if you use antiemetics, it is not going to cause any significant reduction in the potency of the action of the semaglutide molecule. Now if we look at the data in terms of complications, it is able to reduce macrovascular complications. So the major trial for that, for macrovascular complications. So macrovascular means large blood vessels. So the large blood vessels with diabetes are involved in your heart, it is involved in your brain, which is in the form of stroke, in the form of myocardial infarction, in the form of heart failure. And semaglutide is able to cause reduction in this risk of macrovascular complications 24%. It is able to reduce your risk of developing a non-fatal myocardial infarction. It is able to reduce your risk of developing an episode of heart failure as well. So overall, this 3-point mortality scale, which is your risk of developing myocardial infarction, your risk of developing heart failure, and risk of involvement of your stroke, is able to be reduced by semaglutide to the tune of 24%. Now, in terms of microvascular complications, the major trial is the flow trial. So that is your involvement at the level of the kidney. So with semaglutide, there is reduction in your risk of microvascular complications by 23%. You are able to delay the onset of dialysis in patients who are at risk of development of dialysis of CKD by almost 1 to 1.5 years with all these GLP-1 analogs. And at the same time, you are able to reduce your microalbumin excretion. So before there is increase in creatinine, there is loss of protein from the urine, which is reduced by semaglutide to the tune of almost 39%. So there is improvement in HbA1c control. It is the most potent molecule, bar insulin, for reduction in your HbA1c control. It is able to cause reduction in risk of macro and microvascular complications as well. Now, this is also associated with weight loss. Now, as we have discussed with GLP analogs, the weight loss in patients with diabetes is lesser as compared to non-diabetic individuals. So, in non-diabetic individuals with semaglutide, the weight loss is to the tune of 15%. However, in diabetics, it is slightly lesser. It is on average 10 to 11% at the end of 1 year, and this weight loss happens in 70% of the individuals. So of 10 patients you start on semaglutide, 7 patients are able to reduce significant amount their body weight. So there is reduction, there is improvement in HbA1c, there is reduction in risk of your micro and macrovascular complications, there is reduction in your body weight, and this is also with a very low risk of hypoglycemia. So in terms of hypoglycemia, it is most severe with insulin and insulin secretagogues. So anything which causes increase in secretion of insulin, which is sulfonylureas, may it be urepa, that is repaglinide, they will cause a significant risk of hypoglycemia. Now, the mechanism of action of semaglutide is such that it is dependent on glucose. So there will be increase in insulin secretion only if your blood glucose values are high. If your blood glucose values are normal, there is no release of insulin as per se with semaglutide. So that is why it is associated with a very low risk of hypoglycemia. But when you are starting semaglutide in patients who have diabetes, you should be very cautious, because they might be taking drugs which are already putting the patient at risk of hypoglycemia. So they might be on insulin, they might be on sulfonylurea, and ideally when you are starting a patient who is well controlled with sulfonylurea or insulin on semaglutide, you should be stopping the sulfonylureas completely. If the patient is already uncontrolled and you are starting semaglutide, you should be significantly reducing the dose of semaglutide with the molecules. Now, in the recent times, there are new generic molecules available. So what is the difference between the innovator molecule, that is Ozempic, the innovator molecule, that is Wegovy, and the innovator molecule, that is Rybelsus, as compared to newer generic molecules? So the most important for me as a clinician is that I consider semaglutide in the same class of drugs as insulin, in that rather than the manufacturing, what is the cold chain? How does the drug come to me from the factory to the pharmacy? That is very, very important. And that is why the maintenance of cold chain. So all the prescribers here, most of us are still using Act Rapid, and the main reason is that while there are other molecules available which are able to cause control of your blood glucose with insulin, you want a drug which has absolute maintenance of cold chain. And I think so whenever we are choosing the molecule, we need to be very sure that the drug is able to reach in the pharmacy and it is stored in the pharmacy in a very proper cold chain way. Along with the cold chain, the second problem is impurities. So anytime these synthetic molecules are prepared, you are not sure if during the process of their manufacturing, if there are any impurities which are there in the molecule or not. So there is a publication from 2024 which has studied 80 generic molecules. Now those molecules are not the ones which were launched in India, but what that study has shown is that there is significant increase in the risk of impurities in the molecules which are synthesized as compared to the biologic molecule which is available for almost 8 to 9 years now, and it has been used in more than 100 million individuals. So anytime you are using innovator, you are deciding on innovator versus generic, the main points to be considered are the maintenance of cold chain and the presence of impurities. Now at the same time, the generics have been only used per molecule in 400 to 500 individuals, while with innovator molecule the experience is there in more than 100 million individuals. The innovator molecule which is Ozempic, it has approved labeled indication to able to reduce your risk of developing a cardiovascular complication. It has approved indication to reduce your risk of developing a kidney event, and it has an approved indication to reduce your risk of developing a liver involvement. So this is approved, while the newer molecules, the generic molecules, they only have approval for control of blood glucose. They are not yet approved. Many molecules are not even approved for reduction of body weight. They are not even approved for weight loss as well. Of course, they are not, the data is still not available whether they are able to cause the same reduction in risk of your macro and microvascular complications or not. So if we look at the dosing with semaglutide, in terms of diabetes management, the main molecule is Ozempic, which is a subcutaneous injection. It has to be given once weekly. Yeah. We have discussed most of the slides. Just go through them. So in terms of the dosing, we generally start with 0.25 mg weekly dose, and we up titrate it every month. So this is the usual approved indication in the trials, but this is not what we follow in our clinical practice. In our clinical practice, the dose up titration and the change in dose is very individualized. If the patient, just like insulin, if the patient is able to have a good glycemic control with a lower dose, you will keep the patient on a lower dose only. If the patient requires more tighter glycemic control, if the patient needs additional weight loss, that is when you will be up titrating. So the dose will go on from 0.25 mg, 0.5 mg and 1 mg. Now in terms of diabetes management, after 1 mg dose, the improvement in HbA1c at higher doses is completely, it is only 3 to 4% more. So beyond 1 mg, the approved doses are 1.7 and 2.4 mg for obesity, and for diabetes, some individuals do use a dose of 2 mg, but it does not cause additional HbA1c reduction. So beyond 1 mg, if you are up titrating the dose, you are up titrating the dose only for further reduction in body weight, not for improvement in your HbA1c. Now in terms of diabetes management, the other molecule which we have available is Ribelsus, which is the oral semaglutide molecule. So it has to be taken empty stomach in the morning, 30 minutes before your breakfast. Now this is very important because this oral molecule is completely covered with a molecule called as SNAC, and inside the SNAC it is the same injectable semaglutide which is available. So injectable semaglutide is a peptide, and anytime any peptide goes into your stomach, the acid will completely destroy your peptide. So that is why it is covered with something which is called as aminocaprylic acid, that is SNAC, and to ensure that it is completely properly absorbed in your stomach, this snack requires that it should be empty, it should be present in your stomach for 30 minutes. Now if it is present in your stomach for more than 30 minutes, it is going to cause gastric side effects. If it is present for less than 30 minutes, it is going to cause reduction in absorption of semaglutide. So this is very important to explain to all your patients, that first thing in the morning you take your semaglutide, take it with half a glass of water and wait for 30 minutes, and exactly after 30 minutes take your breakfast. So this is where Ozempic becomes the first line optimal therapy. It is the most powerful glucose reduction agent available, with compelling weight loss, with cardio and renal protection, with a convenient once weekly dosing at a very low risk of hypoglycemia. Thank you very much.